Thank you, Mr. Chairman, Co-Chairman. Thanks the organizing committee for inviting me to give this lecture. As Dr. Faisal earlier mentioned, this lectures geared actually for the primary care physicians and how can we tackle some challenges in the family practice or the common GI problems in primary care physician practice. One of the commonest really problem in family practice is reflux disease. Reflux disease, we're going to go through the definition, epidemiology, pathophysiology, and more importantly, some of the important and common challenges that face the general physicians and how to tackle these problems. Definitions in 2006, Montreal Consensus Group defined reflux disease as a condition which develops when the reflux of stomach contents causes troublesome, which means there is a reflux and there is symptoms. So this is probably the definition also being mentioned by the ACG in 2003, ACG guidelines. It can be episodic, more than 2 times weekly, or it could be a chronic condition almost on a daily basis. Reflux esophagitis, a subset of reflux disease, which means esophageal injury, whether erosions, erythema, or can be an ulcers. It's not actually uncommon problems. Indeed, 44% of United States adult population have heart pain at least once a month. Almost talking about 1/5 of your population complaining at least once a month of this problem. 14% have symptoms on weekly basis, and almost 7% of your population complain of this problem on daily basis. And as you advance in age, this actually problems come more prevalent in these patients. We don't have exact prevalence on our society in Saudi Arabia, although as a gastroenterologist and probably primary health care physicians and internists, we always face such a problem on daily basis. There is a recent study, although the preliminary result not yet, but this is a result done by students at King Khalid University Hospital, where they actually tackle moles and asking about the GERD symptoms. Hopefully we'll have these data in the near future. It's very important that we know reflux disease is a precancerous condition. Reflux symptoms more than 3 times weekly, or recurring symptoms more than 20 years have almost 15-fold greater risk of esophageal cancer. So it's a common problem and can be serious also problem. So it's a very important disease to really know. What are the pathophysiology of reflux disease? Many actually pathophysiology, whether this is impaired esophageal clearance and impaired salivary function. With a hiatus hernia, reflux could go from the stomach, goes up to the esophagus. Transit, inappropriate relaxation of lower esophageal sphincters, or sometimes can be even as what we call delayed gastric emptying. What are the clinical manifestations? When we hear clinical manifestation, reflux disease, we always refer to heartburn. Heartburn can be defined by the patient by many symptoms, especially in Arabic. So we have to be very careful when we actually take history of reflux disease, because that can really change from society to society and depend on the language and the expressions of the patient himself. So that's a very important really things that we have to concentrate on. Regurgitation could be a complication, or sometimes dysphagia can be a presentation. However, we always have to make sure when we have dysphagia we don't have complications, or we could deal with other possibilities like eosinophilic esophagitis. Other symptoms include If classic symptoms of heartburn, regurgitation exists, then you made actually your diagnosis. You don't need any more sophisticated diagnostic tests. You can treat right away and wait and see. You have to be careful that heartburn not always reflux disease. Other causes of esophageal injury could be eosinophilic esophagitis, or CMV infection, candida esophagitis, pill-induced esophagitis. Most of these patients actually present with dysphagia, downophagia more than heartburn. However, they could present with heartburn. And this is one of the possibilities sometimes when you have a reflux or refractory reflux disease or refractory heartburn. And non-esophageal causes coronary disease. I still remember when a patient came to me about 4 years ago, a 55-year-old patient who's referring to his chest and saying, I have heartburn, عندي حموضة, that's in Arabic. When I saw his hand, I reminded Levine sign, I just was lucky and I ordered ECG, start ECG, and showed ST elevation 4 millimeters. This patient went for primary angioplasty. So we always have to be careful when we hear reflux disease. Alarm symptoms, it's very important to realize what's alarm symptoms or signs: dysphagia, GI bleeding, adenophagia, vomiting, weight loss, iron deficiency anemia. These are alarm signs that we have to be careful when we encounter these symptoms. How do we make diagnosis? We could, as I mentioned, history, typical history. You could try the medication and see. You could start with H2RA or any other Zentac, cimetidine, or you can start with any forms of proton pump inhibitors. Expect response usually in 2 to 4 weeks. If no response, you could change if the patient H2RA to PPI, and you could maximize the dose. Usually we say within a 2-month trial is enough really to know if this is a reflux disease or not. How about gastroscopy? Do we have to do gastroscopy for every reflux disease? The answer, absolutely no. However, there's some patients that we need to do gastroscopy. If there is any alarm symptoms or sign, I think this is a very important test that has to be done. Rule out any esophageal cancer, complication of reflux disease, or other causes like pill-induced esophagitis, CMV infection, or eosinophilic esophagitis, which is a forgotten actually disease that we see more commonly over the last few years. Or a patient who fails a medication trial. You gave him 2 months of PPI with no response, then you have to look for a cause. Or a patient what we call the high-risk patients. White, male, more than 45, more than 5 years of history. How about our patient? I have to still, in my practice, consider these patients as white, and any patient with a chronic more than 5 years, more than 40 years, I usually consider gastroscopy for this patient to rule out complication like Barrett's esophagus. Absence of endoscopic feature does not exclude reflux diagnosis. This is a very important. Indeed, in literature, 50 to 70% of our gastroscopy in reflux disease, a very typical reflux disease, being negative. There is no esophagitis, there is no erythema, no erosions. So we always have to be careful in these cases, not naming a patient doesn't have reflux disease based on gastroscopy because it's insensitive. Allows for detection of, for example, esophagitis or complications, stratifications of these patients, how likely this patient going to respond to the treatment, and could be management of esophageal manifestation or complication of reflux disease. 24-hour pH monitoring, do we need it? It's accepted standard for establishing or excluding the presence of reflux disease. Don't need it for all the patients. Probably it can limit this actually indication for very few patients who ask for surgery or refractory reflux disease, patient being treated with no response, gastroscopy is normal. These cases you really need to confirm their diagnosis before you send them to surgery or you call them a reflux disease. How do we treat these patients? There are certain goals: symptomatic reliefs, or heal esophagitis, or avoid complications. Symptomatic relief can start with lifestyle modifications: avoid large meals, avoid caffeine, chocolate, onion, peppermint, fatty foods, and smoking, and avoid lying down within 3-4 hours after meal. Elevate head of bed 10 to 20 centimeter. Avoid medication that may potentiate reflux disease, like calcium channel blockers, nitrate, and lose weight. Probably one of the most important that I always tell my patient, in addition to avoiding some certain foods, is avoid lying down within at least 2 to 4 hours, especially at night. This is what I always really tell my patient. This is the most important in terms of lifestyle modifications. How do we start? You could start with antacid. You could start with H2RA blockers. It really depends on how frequent is this reflux disease. Although most of people would start probably with proton pump inhibitors, however, in certain patients, I think H2RA can do a better job, especially with those with intermittent heartburn. They can take H2RA on demand. PPI, better control of symptoms with PPI versus H2RA, and better remission rates. Faster healing of erosive esophagitis with PPI versus H2RA has been shown by many studies. It can be taken 15 to 30 minutes before meals, breakfast especially, ideally after fasting. Symptom relief in 71 to 96%. Heals esophagitis within 4 weeks. 80% recurrence within 6 months when discontinued. And this is a common really scenario where you have a patient came to you and said, well, I take the medication. Unfortunately, when I stop the medication, it comes back. I don't have a reflux disease. This is so common scenarios that come to our clinics. This is unfortunately what's usually happen. This is a reflux disease. I always tell my patient this is like, most of the time it's like diabetes or hypertension. Unfortunately, you have to continue on these medications. And continuing with this medication can be chronic, or can be, as we say, on demand. And that's really based on the patient's symptoms. The patient coming with, for example, every week out of 2 months he will have these symptoms, then I tell him, okay, you can take this on demand for about 2 weeks. Whenever you start having symptoms, just continue this PPI for about 2 weeks. Or you could have this patient, if it's daily basis, then I always tell the patient, this is not only for the symptom relief, this is a very important to stop a complication like esophagitis, strictures, and probably also peritosophagus and dysplasia. On demand, especially on those patients, it can be substantial cost saving in some of the patients. There are some certain patients where they have a nocturnal, what we call acid breakthrough. They actually wake up at night complaining of this heartburn, or sometimes early morning heartburn. These sometimes patients on once a day, or can sometimes be on twice a day, high dose PPI, 40 milligram, for example, esomeprazole twice a day over the last 2 weeks, and then started to have these symptoms. So these patients, you can actually give them Zantac or H2RA blockers at night, and it's actually can work very well. Sometimes when you continue the H2RA blocker, they lose usually their response within time, so you can tell them take it for 2 weeks to 3 weeks, then you can take it on demand. Strategy for patients refractory to standard pharmacotherapy: maximize your dose. Make sure you tell the patient before. This is a very important really message, that PPI has to be taken before meals. It only works, I would say, it works maximum when it takes in before meals. You could add H2RA at night. Laparoscopic fundoplication, always confirm the diagnosis before you do this. You need esophageal diagnosis, in my opinion, to rule out eosinophilic esophagitis. In these patients who are not confirmed For example, they have pH monitoring negative, they have normal gastroscopy. All of this is a reflux disease. Then you have to always make sure they don't have any esophageal manometry problems, or they have a positive pH monitor acid reflux. PPI is probably what we usually give this patient, and it's always come to the patient public awareness, especially nowadays, with side effects of PPI. And the most probably common things is fracture and osteoporosis. Many patients actually would come to you now to your clinic, and he would ask, what about this and what about that? So we have to tackle these problems also. We have to be aware of what's the PPI side effects. Another thing especially common in the internist, primary care physician and the cardiologist is the link between clopidogrel, Plavix and the PPI. C. diff, diarrhea and its rule. There is FDA actually class warning, and there is American Journal of Gastro in 2008 with some association. Pneumonia, meta-analysis of RCT failed to show this association, although there's some actually studies that refer to a possibility of pneumonia. In one of the studies showed it's only when you start the medications within 2 weeks you increase your risk of pneumonia, although as I mentioned a meta-analysis of only the randomized clinical trial didn't really show any increase of this pneumonia association. Magnesium deficiency, this is one of the things that I think we have to realize. It's still very, very rare, only reported cases, maybe 50 cases so far. This is one of the things that we have to. A common actually at least I would say misconception that there is a PPI, there is a relation between PPI and cancers, whether GI cancer or colon cancer. So far, there is no single case, so there is really no association between PPI and cancers. And it's not a new thing. This is since 1990 with PPI on board, and we still luckily don't have any kind of association between whether gastric cancer or colonic polyps or cancers too. About PPI and fractures, which is, I think, a common concern by the patient. In consistent study results, PPI does not increase risk of fracture among patients with no pre-existing risk factor. In one study showed the patient with pre-existing factor, maybe there is a risk of fractures, especially the hip fracture. Long-term PPI, 5 to 10 years, not associated with accelerated BMD lows. There is one study showed that when you start PPI, the baseline BMD drop. However, with continuity, there is no. So far, there is evidence does not justify really routine prophylaxis. So most of the patients usually, if they are actually having pre-existing, for example, you're treating a 50-year-old female postmenopausal, then this is a very good actually important, and you have to really realize these patients may be actually at a higher level of osteoporosis and probably fracture in these patients. So you have to prophylaxis these patients. How about PPI and Plavix? It's controversial over the last, I think, 3 years. There's FDA class warning in 2010. And finally, Cogent trial in New England Journal of Medicine 2010, 3,625 patients. 2 groups, both of groups on aspirin. One group on PPI and one on placebo. No significant difference between placebo and omeprazole in terms of cardiovascular events or MI. So they're the same. Does not, which means that omeprazole or PPI didn't increase the risk of cardiovascular events as being actually mentioned in some of the observational studies. Increased risk of GI bleeding on the placebo group. Indeed, not only that, indeed, mortality from GI bleeding and significant p-value of 0.007. So the conclusion for those with significant association, probably confounded by indication. I mean the observational study that been associated with this, probably the sicker the patient, probably he's in PPI, and that's why they found probably more of cardiovascular events in such patients. How about anti-reflux surgery? Do we have to continue on PPI forever, or do we have to refer every reflux disease for anti-reflux surgery? Anti-reflux surgery is for failed medical management, patient preference, girder complication, medical complication attributable to large hiatal hernia, which means the patient complaining of heart pain and regurgitations or vomiting. This PPI would not work really well for the regurgitation. Typical symptoms with reflux documented on 24-hour pH monitoring. Candidates, EGD proven esophagitis, very good candidate for these patients, for anti-reflux surgery. They should have also normal esophageal motility, and they should have at least partial response to acid suppression. 75 to 90% effective at alleviating symptoms of heart pain and regurgitation. What's happened post-surgery? You have, the patient has to know that 10% have solid fold dysphagia, which most of the time transient. However, some patients actually might continue. Within 3 to 5 years, almost half of the patient will require or will go back to anti-reflux PPI. 1 to 2% require reoperation for bleeding. No evidence of Barrett's regression or prevention of cancer, despite what some surgeon actually says. PPI or surgery, what do we do? Lotus trial in JAMA 2011, 554 patients were randomized to continue to receive esomeprazole or to undergo laparoscopic anti-reflux surgery over 5 years. Symptoms stayed in remission in 92 versus 85% of the surgery, with no significant difference between these two groups.
Dr. Abdul-Rehman, 1 minute, please.
Sure. When PPI works, this is the message: surgery offers no advantage. Even if the patient prefers to do that, you have to tell him this message. Management of GERD during pregnancy, usually self-limited. Try management with antiacid, lifestyle modifications, sacral fate, 1 gram TID. Avoid drugs during the first trimester. Can start with H2RA, or sometimes we can use PPI. A meta-analysis, 1,530 exposed patients. There is really no significant difference in the risk of major congenital birth defects, spontaneous abortions, or preterm delivery. Most of the PPI, they are class B in pregnancy, so they can be safely used, although, as I mentioned earlier, we usually avoid any kind of medications unless necessary. How about GERD and H. pylori? This is a very common scenario in these patients. Do we have to treat these patients with H. pylori? The link is complex, but in summary, don't treat unless there is an indication to treat H. pylori itself. So we don't treat a reflux for actually H. pylori in associated reflux to improve the reflux. Most of the times, indeed, this reflux gets worse, because this is a hypersecretor. Once you treat H. pylori, they actually reverse them to hypersecretors. There's something we call functional heart pain that we have to know about it, but this is after a normal esophageal manometry, normal ambulatory reflux monitoring, normal esophageal acid exposure, normal upper GI endoscopy with esophageal biopsy. Then you can call this patient functional heart pain. And thank you very much.
Thank you, Dr. Abdul.